Good day, everyone. My name is Mohammed Rakibul Islam, and today I will present our research title Explainable Machine Learning for Predicting 3-month Readmissions in Heart Failure Patients, a calibration and a risk stratification approach. This work was conducted with my co-authors, Khandagar Mehrab Hussain and Dr. Shifat Momin from the Department of Electrical and Computer Engineering at North-South University, Bangladesh. Our study focuses on using electronic health records to predict readmissions in heart failure patients. The goal is to support better and more timely clinical decision making. Heart failure affects more than 26 million people worldwide. It remains one of the most serious healthcare challenges today. Most existing prediction models focuses only on a 30-day window period, but many patients continue to face serious risks well beyond the first month after discharge. This medium-term gap is largely unmonitored, so we developed an overlap-aware calibrated machine learning framework to detect high-risk patients early. The impact of heart failure readmissions is both clinical and economic. In the United States alone, annual spending on heart failure patients exceeded $52.4 billion. This makes readmission one of the biggest drivers of hospital resource depletion. In countries like Bangladesh, the situation can be more severe. The lack of universal health coverage means families often face catastrophic out-of-pocket expenses. This can push them into a cycle of medical poverty. Reducing avoidable readmissions can improve patients' outcome. It can also ease the financial burden on vulnerable families. We identified three major challenges in existing studies. First, most models are limited to a 30-day windows. They miss the critical medium-term recovery period. Second, readmitted and non-readmitted patients often show very similar clinical data distributions. This feature overlap makes prediction more difficult. Third, many machine learning models are hard to interpret. Black box predictions limit the trust clinicians can place in them. Our goal was to build an explainable framework that handles class imbalance, reduce feature overlap, and provide reliable clinical risk prediction. Let me walk you through our pipelines. We started with a dataset of 1,965 heart failure patients from Jinggang Fourth People's University Hospital. The data had over 63,000 missing values. To handle this cleanly without introducing bias, we remove columns missing more than 55% of their data, but manually retained critical clinical variables like left ventricular ejection fraction, which is important for this prediction. We then implemented an iterative neural autoencoder-based imputer, or INAA, to preserve important clinical patterns. Next, to address feature overlap and class imbalance, we applied fuzzy overlap-based undersampling, or OBU. This removes ambiguous data points and improves class separations. For feature engineering, we added clinical features like LACE plus and hospital score, and we also built custom risk indicators based on high risk medicines, such as rare disease indicators, high risk drugs indicators, and high risk drug count and ratio. Third, we run a multi-layered feature selection process using Pearson correlation, Boruta random forests, and XGBoost with SHAP, and narrowing down our data to the top 90 clinical features. Then finally, we trained ensemble models and applied isotonic calibration to produce reliable risk probability estimates. Among the 1,965 patients, 485, about 25%, were readmitted within 90 days. Looking at the table on the slide, we can see clear differences between the two groups. Readmitted patients had a significantly lower systolic blood pressure, 124 mmHg compared to 130 mmHg in non-readmitted patients. Their kidney function was also worse, with higher creatinine levels of 99.5 versus 84.35 micromole per liter, and a lower eGFR of 57.28 versus 69.18. Also, 36.9% of readmitted patients were in NYHA class 4, compared to only 27.8% in the non-readmitted group. All these differences are statistically significant with p-values below 0.001. For this study, recall was our most important evaluation metric. In healthcare, missing a high-risk patient can have very serious consequences. So we prioritize models that can catch as many at-risk patients as possible. Among all models, X-Study achieved the highest recall of 78.7%. CataBoost achieved the highest ROC curve score of 66%. This results shows that our frameworks effectively identify patients at risk of readmission. Prediction alone is not enough in clinical practice. So we used the calibrated XGBoost model to group patients into three categories: lower, moderate, and high risk categories. As you can see in this table, the lower risk group had an observed readmission rate of 15%. The moderate risk group was at 21%, and the high risk group showed a readmission rate of 37%. This separation is clinically meaningful. Lower risk patients can continue standard follow-up. Moderate risk group patients may benefit from closer monitoring, and higher risk patients should receive intensive post-discharge management to prevent readmission. To improve transparency, we used SHAP analysis to identify the most influential features. The top predictors was mitral valve EMS. A lower EMS ratio signals diastolic dysfunction, which directly increase the risk of readmission. Systolic blood pressure was also highly important. A lower value at discharge indicates reduced cardiac output and poorer blood flow. Finally, renal biomarkers, especially creatinine and eGFR, highlighted high cardiorenal risks. Worsening kidney function is a strong warning sign for heart failure patients. These findings match well with established clinical knowledge. They help clinicians understand exactly why a patient is flagged as high risk. In conclusion, we developed an explainable and calibrated machine learning framework for predicting 90-day heart failure readmissions. By combining fuzzy overlap-based undersampling, probability calibration, and SHAP-based explanations, our approach provides reliable and clinically meaningful risk predictions. One key limitation is that our data come from a single hospital. In future work, we plan to validate this framework across multiple hospitals. We also want to include post-discharge factors like medications adherence and social support. In a real-world setting, this tool could be built directly into a hospital digital record system and flagging high-risk patients automatically at the point of discharge. Thank you very much for your attention, guys. I would be happy to answer any questions.